So welcome everybody. This is a virtual judicial forum, and we're honored to have Senator Tillis's team reach out to us for this fact-finding and partnering opportunity today. Today our speakers will be discussing their evidence-based community programs, and they will share some outcomes data, and they will offer some insight into what's needed from lawmakers like Senator Tillis as we move forward. Senator Tillis has set Mr. Williford to represent him at this forum. Seth is the legislative staffer for Senator Tillis, managing the Senator's criminal justice portfolio, and his primary responsibilities are to research and analyze public policy issues affecting North Carolinians and to advocate on behalf of federal agencies. In practice, this means becoming educated about policy issues, working with constituents to understand how federal policies are helping or hurting them, their communities, and applying this knowledge to advise the senator on what policies and programs to support. And this really is what's going to guide our educational forum today. Mr. Williford is an undergraduate with law degrees, is an undergraduate and has a law degree from Wake Forest University. And before law school, he performed constituent casework for a congressional office. He has worked on political campaigns as well. And again, we are honored to have Mr. Williford with us today, and let him say a few opening words.
Well, thank you so much, Dr. Richardson, and thank you to each of you for participating today. I really can't express my gratitude enough. This is a really important issue to the senator, to the state, and to the country, and the opportunity to learn from you about what strategies are working, about what the impact of federal spending has been, the impact of federal policies or lack thereof is very helpful to me and my ability to educate the senator and to advise him on what we're seeing on the ground, what's working, what's not. And yeah, this is the favorite part of my job, because I get to work with the folks like yourselves who are really making an impact in the lives of North Carolinians each and every day. And so I'm very grateful for your time. I'm really looking forward to a wonderful forum and to learning more about your efforts.
Thank you very much. And this isn't the first opportunity we've had with your office. We've worked over the years with James Estes, and we want to continue to offer forums and opportunities like this. We're going to start with Mr. Bachman. He's a program director, and kind of frame the conversation today about evidence-based practices of care.
Thank you, Corey, and thank you, everyone. It really is an honor to be here today. I just kind of wanted to start the discussion of just kind of touching on the importance of evidence-based care in addiction treatment, especially with looking at, if we look at the definition of addiction based on the American Society of Addiction Medicine, we see that it is a neurological condition, it is a chronic medical condition, not a moral failing. It is the only disease that is still considered to be a crime in this country. And if you look at between the definition and the quote, we really see the importance of treatment of addiction as a disease and using a biopsychosocial treatment model. So the ASAM criteria that were developed in the 80s and are now in use by over 30 states identify 4 broad levels of treatment and an early intervention level. As we look at that, and you'll see those levels down there, but and we'll go more into what some of those examples look like from our programs. But it is really important to determine an appropriate clinical fit and match the severity of the disease to the appropriate level of care. So these criteria that were developed were based around treating the entire person, and it really advocates an integrated care model. And so if you look at those various criteria, you can see where in evidence-based treatment, it's important to address each of these 6 criteria, including things, not just the actual substance use, but also emotional issues such as trauma. And a lot of what we're going to be discussing as we move through today is looking at some of the recovery and the living environment conditions and some of the resources that need to be pulled in as part of an evidence-based care model where we're providing these services to these consumers. So when we look at the actual levels of care, the integrated care of Greater Hickory offers, we see that we provide all of these services using the Project Match 12-step facilitation model, and we maintain fidelity to that treatment model. As we move through, we also in providing these services, we also use cognitive behavioral therapy, motivational interviewing, But when we're developing the treatment plan, we take consideration for each of those 6 ASAM criteria when determining what level of care someone needs to be placed in. And so we look for things with good clinical fit. So somebody might need to be placed in a higher level of care if they were homeless, or if housing was an issue, or if they had some of these additional stressors in their life. But a huge part of evidence-based care, addiction treatment alone is not sufficient to turn the corner on addressing the addiction issues of our state. And so we need the support of community partners, working with the sheriff's office and working with just a huge number of other community agencies. And partners has been really fantastic in helping us get linked up to a lot of these resources. And we're going to be discussing some more of these as we move through today, especially some of the housing issues. And there's so many programs that we could go into, talking about L.E.A.D and talking about everything else, but it's important to recognize that these are included in evidence-based treatment, and they make a very significant impact. I want to touch very briefly on treatment outcomes. We'll be looking at more outcomes throughout the day. One that I wanted to mention, when we talk about this integrated care model and the effectiveness of that, we use a outcomes tracking system called ACORN. And if you look at the 3 months pre and post a lot of the stay-at-home orders, you can see that the scores remained very stable, actually improving slightly after we began lockdown. And as we look into moving forward, we need to identify what factors are helpful in helping these patients to address a lot of these issues. And if you compare these to the statewide average for all other programs that take part in this outcomes tracking of a 0.82, you can see that there is something we're doing that is making a substantial difference. I do want to touch briefly also on some of the challenges and successes. The transition to telehealth was huge. We were previously entirely in person, and so there was a lot of issues with that transition. We're going to be touching on a lot of these judicial issues as we move through today. And of course, funding is always an important thing to consider in terms of this, and that's one thing that's going to come up several times as we have our discussions. And one area that we're hoping that the state and Senator Tillis can help us with. And also, there will need to be some discussion of the predatory practices. And by that, I mean the providers out there, either physicians or other agencies, that are not using evidence-based treatment. And it might be someone who's only prescribing medication, but not addressing any of the emotional issues, not offering any supports with those social environment issues to actually help that person achieve meaningful recovery and stable recovery from their addictions. Thank you.
Thank you, Randall. And so what you see with these evidence-based models of care and these integrated treatment planning models, the addiction provider cannot do it alone. He needs all these other resources, and that does frame for us the rest of the conversation and the other needed interventions, as well as evidence-based models of prevention, and we'll talk to that as well. So next, I'm very excited to talk about our L.E.A.D program here in Hickory, and I'll give it over to Major Reed and his team.
Good morning. Thank you for having us. I'm here representing L.E.A.D Catawba. L.E.A.D Catawba is actually a countywide initiative and program that encompasses 9 law enforcement agencies here in Catawba County, as well as our partners in this, Partners Behavioral Health, the North Carolina Harm Reduction Coalition, and on the call as well, we have Wesley Rogers, who is our case manager for our program. And I'm just going to give you a snapshot of what L.E.A.D is and what it has done here in Catawba County and how we came about it. Back in 2018, here at HPD, we were faced with a lot of the same issues facing a lot of communities in our state with regards to drug addiction. Specifically in the media, you were seeing the opioid addiction and crisis. However, here in our county, we were seeing primarily methamphetamine and opioid, as well as some other substance abuse. So we were looking for ways in law enforcement to break the cycle of rearresting individuals who were suffering from drug addiction, which was fueling their criminal behavior. And so we looked at this for quite a while. L.E.A.D is an acronym. It stands for Law Enforcement Assisted Diversion. We looked at programs across the state and country, and we settled on L.E.A.D for a number of reasons. One was the fact that we felt like it really addressed more holistically the issue of addiction, excuse me, than a lot of the other programs that we saw. Like I mentioned before, we were dealing with a myriad of addiction here to include methamphetamine and opioid. It wasn't one substance, and there wasn't a magic bullet that we saw that could, fix or help this. So after a lot of research and talking to everyone from clinical providers to other law enforcement agencies to actually individuals suffering from addiction and involved in criminal activity, we settled on L.E.A.D. And how it works is our officers are empowered to have another tool in their tool belt opposed to arrest. So we find a lot of individuals in our community were being arrested for lower level crimes such as shoplifting, misdemeanor larceny, possession of user amounts of narcotics. And when we were having to place these individuals under arrest, it was going into the judicial system. They were either coming right back out with having received no assistance for their addiction, which then put them in a position to recommit offenses. And as those offenses build, they also build in severity, so on and so forth, affecting the individual, affecting the community. And so we decided that we were going to try L.E.A.D. So what happens is our officers are the tip of the spear, if you will, in this program. And when they encounter individuals in the community, and in one scenario, let's go back to what I mentioned before. Let's say it's a misdemeanor call for service for a larceny. And our officers are out with this individual. After some conversation, our officers realize that this individual is committed this offense and it's being fueled by their addiction to a substance, like methamphetamine or opioids. If this person is willing to enter the program, the officer will offer them L.E.A.D. And what that entails is a charge diversion. So instead of charging the person with that crime at that time, that individual is diverted directly to Wesley Rogers, who was our case manager. And that individual is then assessed. They go through a full clinical assessment through Catawba Valley Behavioral Health, who is who Wesley works for. And then Wesley works on connecting them to services, kind of a wraparound approach. We find most of our individuals that we deal with are people who not just have an addiction to a substance, but they also perhaps have a mental health issue or perhaps a housing issue. I mean, there's a myriad of things that have led to where they are when they encounter the police officer. So at that point, the officer, once we call it a handoff, once that handoff is made, an introduction to Wesley, that person then has a certain amount of time, which is 14 days, to get that clinical assessment done. And if they do not complete the assessment, then the officers will then come and they can then charge the person with the original offense. If they do complete their assessment, then Wesley connects them to services and works with them hand in hand and follows them through that. And the police officers are no longer involved in that particular individual's case. The other way that we refer people into the L.E.A.D program is called a social referral. And actually, this represents most of our referrals. And this is when an officer in the community knows someone that is suffering from addiction and has not necessarily committed an offense that a charge needs to be diverted from, but just knows individuals from our community policing model where we attend a lot of neighborhood meetings. We're always in the neighborhoods. Our officers are assigned to permanent districts, so they're not moving all around the city. So they get to know the people in their area. They can offer this program to just a community member who they know is suffering from addiction or maybe knows has had issues in the past. And at that point, the process is the same. There's an introduction to Wesley, our case manager, who completes a full clinical assessment. And at that point, they can enter the program as well. We've seen a lot of success. This program started in 2018 in May. We right now are seeing a 64% decrease in criminal activity from folks who enter the program. I'm going to throw just some latest statistics up here that'll show you that. And so just some quick reference points for the program. May of 18, as I mentioned, there have been 81 total people referred into the program since then. 49 of the 81 referred were social referrals, and 32 were charge diversions. 24 of the 81 were referred out to service providers in other counties due to residency. So what that bullet means is one of the requirements to be in L.E.A.D Catawba is you have to be a resident of Catawba County. And that goes into being able to follow them through the program. If you live in another county, it's very difficult to try to track your progress and meet with Wesley, so on and so forth. And a lot of the connections that Wesley has made through programs to attach people to are here in Catawba County as well. 19 of the total individuals referred did not complete the assessment, and that goes back to what I mentioned before. That can result in a charge of the original diverted charge, or in the case of a social referral, nothing happens to them because there's no consequence because they were referred in socially. There's no charge. They're just not in the program. The remaining 36 of all of that were actually accepted to and actually participate in L.E.A.D. 2 of those individuals that were accepted were charged with the original diversion. 13 of the 36 people have committed another criminal offense since the program began, which does represent a 64% decrease in criminal activity for folks who are referred and accepted into L.E.A.D. One of the ways we got those numbers is we actually took and looked at criminal histories of individuals prior to the into L.E.A.D and found that we're not talking about individuals, so this is their first offense. Very seldom, as a matter of fact, I don't think we've had anyone that we've referred into L.E.A.D that is a first-time offender, which supports what we were seeing with regard to the folks coming in and out of jail and not getting treatment. And our goal is to try to help folks become productive members of the community once again and hopefully address the issues they're suffering from. And so that's, in a nutshell, that's a snapshot of what L.E.A.D Catawba is. As I mentioned before, the folks referred in, the numbers you saw are referred by all 9 law enforcement agencies. Hickory is the largest part of that in the number of referrals, I think due to the concentration of folks we have in the city limit. And then we have the Sheriff's Department on board as well. We also have the District Attorney's Office on board, which is imperative and extremely important because at the end of the day, the District Attorney is the one who makes the decision upon what's going to happen with those cases. And by having them, we've also been able to assist folks who have done well and are in treatment and perhaps have an old misdemeanor charge that was from a while back, perhaps a driving offense. But maybe Wesley has gotten this individual into some much needed treatment and it's taken some time to get them into that treatment. We're able to sometimes get that continued so that they can get the treatment done before they have to come to court. And what that does is enables them to get that treatment and contribute to that 64% we have right now not reoffending. To my right, I have our crime analyst, Shelly Davis, who tracks all this data for us. That is imperative because without her, I would not know what I'm talking about, quite frankly, with regard to how it's working. And then Wesley does the heavy lifting. And I'll just got a couple minutes here left. So I'll let Wesley kind of talk about that process, which really is, to me, the easy part. We at the police department do the referral. We identify the individuals. That's the easy part. The heavy lifting is done by the service providers and the case manager. So I'll just let Wesley talk a little bit about that.
And before we move on, Major, I had a quick question for you just in terms of the cooperation that you have between your offices and the DA and the other 9, or the total 9 law enforcement agencies. Where did this get started? Was it you brought everybody together and said, we need to come up with this new model? How did this get initiated in the first place? The L.E.A.D model is one that we've seen in other areas. And so I'm just curious how y'all how y'all began that collaboration, how you got the DA on board, the court system, how that all came about.
Well, and it was initially, when we looked at all the models, you're right, there were several L.E.A.D programs throughout the state, as well as some other programs like the Angel program, the Hope program. And we decided at HPD that we were going to do it.
Okay.
And so we were going to do it, and we approached the DA first and got them on board. And then we decided to then reach out to all the law enforcement agencies because we recognized that here in our county, Hickory is the hub,
right.
And a lot of the offenders that we deal with don't live in the city limits. And so in order to be more effective, we reached out to every single department, and initially not every department joined, to be frank, but we went with who would. And now I'm very happy to report that we have all but one or two agencies, and they're very small agencies and don't have a lot of referrals, but we do give them resources and try to help them out. But we pretty much have all the major agencies on board at this point.
Great.
And I think you asked why was L.E.A.D decided upon, and it just went back to us with the kinds of issues we were having here in Catawba County and the city of Hickory. We wanted something that could address a whole myriad of issues. And when we had gone to particularly Fayetteville has a program, we had spoken with some other programs around the country to include Seattle. Seattle, Washington had the very first one. We realized that these weren't going to be members of the communities just suffering from one thing, and that you could just put one person. You have to have the holistic wraparound approach. But the most important thing here was the mindset, I think, of law enforcement, which is, this is my 24th year in law enforcement, and when I started, it was a whole nother profession. You have to be able to step outside of training from so long ago and be progressive and realize that you have to have as many tools in your tool belt as possible to address the myriad of issues we see now. When I started in the 90s, mental health was still attached to the state, and when that changed, this job changed. Yeah. We started dealing with a whole host of social issues as police departments that we were very ill-equipped to handle, quite frankly. And so we've gone out on our own to create programs and to create ways to handle the things that we are going to have to deal with, whether we want to or not.
Sure. Great. Thank you so much. I appreciate that.
I appreciate you guys inviting me to this. I mean, he hit the nail on the head with the L.E.A.D program, and I think it's very important across the country for really an endless amount of reasons why programs like this are important, because you need that person to help walk the path with these individuals. A lot of them have lost a lot of hope just due to family issues or having burnt bridges, so to speak, in the past from just the typical things with addiction. And most of my individuals don't have real housing, they don't have transportation, they don't have employment, they don't have a support system. I mean, they are literally in complete destitute, and that is one of the large factors of why they continue to use, because they feel like, why not when I have nothing else to do but this, because they have no hope, so to speak. And I see L.E.A.D as more than just like a program. We talk about programs and you hear that word, but it's a life-saving device for people and families, because this addiction is a very far-reaching thing that we have to deal with. I mean, it affects not only the individual, not only the community, but if they have children and family as well. And I've been fortunate enough through this program to do the heavy lifting, as they say, but I enjoy it because it's amazing to see when some of these individuals progress. Like I have a family that went from using IV meth in a tent, homeless, who had nothing left to lose, had lost their kids and everything, and now they both have full-time jobs, have got their kids back from the state, and are doing excellent, continue to thrive each and every day in their sobriety. And there's a lot of examples like that, and I look at those things as the true success of programs like this. Even if you just save a few people, I mean, it's completely worth it, because now those children are going to be raised in a much better environment than their parents were, so they have a better chance at success to not be a part of this huge cycle of addiction and all of these type of things. And I just think it's amazing. And then another thing with these type of programs that you don't hear a lot about is the amount of money that these programs could truly save the state and federal government if they really invested in them. it's more of a proactive approach. I mean, it's $85 to keep someone in the Catawba County Jail a day. And if you look at 60% of that being taken away, I mean, you can, crunch the numbers really fast and realize that is an insane amount of money that would be saved through programs like this too. So it's just all the way around. It's better for the individual, for the country, for the state. I mean, for law enforcement, they have that other tool that they can use in their tool belt, and it's awesome to be able to link these individuals with more providers, such as Mr. Richardson and his programs, and just any program possible, housing, HUD, all of that. It's neat, and you'd be surprised at how we have all these programs, but a lot of these individuals are too nervous to reach out or just don't know how to do it. Like I've set appointments with people, like scratching my head over paperwork with them, like, wow, I mean, I couldn't have done this probably on my own if I was in your shoes, let alone being on amphetamines or something else. So it definitely does help, and I just appreciate you guys taking the time to learn about these programs, and I'm here for any questions, and thank you very much.
Thank you.
Thank you, Wesley. That's great, and I thank you for putting that case study in front of us to put some faces and families to those really good statistics. This is a great program, and our company and other providers in Catawba County are very happy to participate in the L.E.A.D program, and specifically working with Wesley. So with that, I am excited to talk about our next program, and everyone's talking about these wonderful interventions. Wesley mentioned about housing, and we'll talk a little bit about housing on the next two. Kayla Guido is a regional housing authority, and has got an exciting program actually with us where we can start really putting some people in housing that are doing well. Go ahead, Kayla.
Hey, good morning. Thanks for the invitation. I'm really glad to be here. It's an honor. Like you guys said, I just feel honored to be here. So I just want to piggyback off of what PD has already said, what Mr. Rogers is saying, what Randall and ICGH is saying, is that housing is such a important part of this recovery piece. So to see some of these clients get into housing and then have a full stable recovery is really exciting, and we couldn't do it without partners like Corey and the L.E.A.D program, because like he mentioned, this L.E.A.D program just started in 2018. Around the same time, HUD started posting regulations that said to not drop clients just based on criminal record or charges or I don't even know what you call that, a first-time offender. There you go. So quick overview real quick of what I do, HUD and my housing authority, and then Section 8 vouchers. So we do not have any public housing units here at Western Piedmont. Other housing authorities do, but we strictly run a Section 8 program with housing choice vouchers. In cooperation with Corey, we've been able to take some of those housing choice vouchers and change them to project-based vouchers. So they're specifically tied to a unit, and one that Corey owns now, or ICGH owns. And then as those clients of Corey's are going through recovery, they're given a voucher to pay a portion of their rent to live with each other in this, and Stacy can speak more on that part, but to live with each other in this recovery housing. So it's important, my point being to the senator and whatnot, it's important that we understand that HUD couldn't do this without these partnerships, because it takes people like what Corey's doing and what L.E.A.D is doing, what Hickory PD is doing through L.E.A.D, what the court system's doing, because without diverting some of those charges, these clients of Corey's or other people coming to apply would not be eligible to apply. We were in a place where we had to deny them. Our hands were basically tied. The rule was just, deny based on criminal drug charges. And now HUD is telling us, hey, look at a preponderance of evidence, see if this is something that's going on for years. And because of programs like L.E.A.D and it's being diverted and these people are getting help, you will see maybe not every single client that goes through the L.E.A.D assessment program, but several of them have really come into a stable place of recovery. And housing's a part of that mix. And we're excited that HUD is changing those rules, and we want to continue to ask them to show leniency. And so if we can collaborate with people like Corey and Stacy and show them how great we just have 12 project-based vouchers right now, but if these 12 individuals do really well and continue in recovery, then it gives us a way to go back to HUD and say, hey, thanks for your leniency, and thanks for allowing us to show you that this is really something that's working. Housing is definitely part of full and stable recovery. There was something else I wanted to mention about the funding piece that's slipping my brain right this minute. I'm sorry. But if it comes to me, I will let you know. And Stacy, was there anything you wanted to add on the process?
Sorry, difficulty trying to unmute. However, what we're doing with HUD and Hickory, those are going to be our individuals that have at least a year of sobriety maintained. Therefore, they're able to, they have already started engaging back out into the community, trying to work on getting a job or getting themselves a car, you know, working on getting their children back. So this setting is for those individuals that have already started treatment, are in a really good place, have been working with a sponsor, are ready to be on their own and try to navigate the world on their own once again. And so these are the type of individuals that we are placing in our HUD units in Hickory. And so far, it seems to be going really well. I am super excited. By the end of this month, we should have 4 individuals ready and going. Right now, we have 2. And so I'm excited to fill the other 8 spots.
Yes, me too. Hey, thanks for mentioning that. And what I was going to mention about funding was when previously I mentioned that we have the housing choice vouchers. We have 1,074 of them given to the Regional Housing Authority. And then we were able to use 12 of them for this project based. But to be able to do that, we had to prove that the funding issues that not necessarily issues, but our average HAP, the average housing assistance payment that we pay out per month, is not going to increase by allowing these individuals who are in recovery to have 12 of our vouchers. And so it's a huge burden that I would honestly love to not have to continue doing or to see. I don't know how maybe Senator Tillis could help us with some of those things. There's definitely ways to write different policy legislation. That's a conversation I'd love to have in the future. But to prove that average HAP, when you're talking about just 12 individuals in a group of 1,074, that we're not going to take a chance on because it's possible that we're spending, $10 more a month in their rent than everybody else who's on the program. I just don't want it to be so centered around the funding, so centered around the money. When we're talking about people's lives, their children's lives, the community is going to be better off with these folks being in recovery and getting jobs and paying taxes. I mean, it all makes sense to support them, even if it costs us $10 extra a month than it does to support the elderly disabled woman down the street that no one has a problem supporting. Does that make sense? I hope I'm saying that well.
And another thing
You absolutely are. Thank you.
would be that these people are actually, when they move into those units, they are still engaged within our program. So they will be receiving services, peer support, groups, individuals out in the community, AA, NA, volunteering. The program continues. It does not stop once they are, approved to move into these units.
Yes, great point, Stacy. I had forgotten to mention that as well. We are definitely working together to see that these families, while they're on HUD assistance, continue receiving the actual program guideline for us, for these folks, is that they continue in Stacy's program while we continue supporting them and paying that portion each month. So thank you.
I have to really thank Kayla at Western Piedmont Council of Government for working with this RFP. It really does hammer down housing tied to treatment, and they were flexible enough that we were able to include a partner in this community or persons who age out of foster care. So sometimes people in communal living in foster care age out and have never lived on their own, and they may be 20, 21. And so we're able to offer, and this is not a shelter. These are very beautiful townhouses. And
Yes.
So they are. I'm very proud of them. And so this is not where somebody feels like they're not in a safe environment, a clean environment. This is their own home. We've had success with our other housing programs, and we always predicate housing with, this is your home, And so I think that's made a big difference in having a place that they can call their own. And it's an important intervention for treatment.
And I don't even know if I've told you this, Corey, but when our inspector came back from the inspection, because to be tied to the HUD funding, you have to pass a housing quality standard inspection. When he came back, he said, "This is really nice." So we're excited. You know, we go to lots of units that we just can't even accept on the program. So to have visited Corey's and know that there really wasn't even any deficiencies or anything to be repaired, few minor things here and there, which is normal for a first-time landlord, and they're just beautiful units. We completely agree with Corey's assessment. They're definitely decent, safe, and sanitary, and we're excited. We're really excited.
We are too, and thank you so much.
Yeah.
That's great. Thank you so much.
Permanent housing is what we're talking about, but let's move over to transition housing for people that are in early treatment. And these are people that are probably coming right from prison. Stacy has been able to really meet with caseworkers in the prison setting. And we'll talk to Vanessa from Partners about the funding for this transitional housing program that is very unique in Lincoln County, and Rebecca Collins, who is that site manager.
Thank you, Corey. I'm happy to be here today to talk about this and, of course, some other partners programs that we'll get to later. I do want to talk about specifically the Lincoln County funding right now, and Partners receives these funds, and they're used for what we're calling Lincoln County recovery support. And the focus was to provide support services to individuals with opioid use disorders with a criminal history background within the past 12 months that are also going into treatment. The goals, and let me share my PowerPoint. I forgot to do that and just started talking. The goals of the program are to promote treatment adherence, prevent homelessness, and reduce recidivism to the Lincoln County Jail. For individuals in treatment for opioid use disorders, the funds can be used for medication-assisted treatment. In a lot of cases, that could be Vivitrol as an example, and that's used for relapse prevention. It's available to the individuals leaving jail and going into treatment. The funds can be used for recovery housing because we want people to have a stable environment that's supportive of recovery and supportive of treatment and helps them be accessible to the treatment, and is also recovery based. We can also pay housing related expenses with that, whether it's rent, security deposits, utility bills for individuals who may be living on their own but are at risk for becoming homeless. We also use these funds for transportation. One of the key things or essential things that we know is that unless you have housing and unless you have transportation, you're not likely to be as successful in treatment and establishing recovery. The funding from Lincoln County is $10,000, and we've been able to serve 6 people with that. That sounds like a very small amount of funds, but Corey and his staff have done a tremendous amount with that. They've worked really hard. They take the initiative. One of the things that Corey did was went out and found apartments to begin this program. And they went ahead and rented them, made sure they were furnished so that when people were eligible to go in, they could go right into housing. Some of the outcomes that we've seen as far as our goals are concerned is that of the participants that are funded, 85% of them, our goal was for the 85% to keep their treatment related appointments. And of the 6 in the program, 100% of them were able to do that. To prevent homelessness, all the participants in the program were housed in a recovery supportive environment. And the ones that were discharged with a stable housing plan in place. And there was only one participant that returned to Lincoln County Jail. And the reason they returned is because they had trouble paying their probation fees and fines on time. So he felt like if he was able to return to jail and complete his time, the fines would be removed. And so he was able to complete probation early. So our goal for that was 80% of participants not returning to Lincoln County Jail. And we actually met that and exceeded it with 84%. A little update on the 6 participants that were in the program. We have 2 residents that are remaining in the program. They're both doing really well. They've completed probation. They're volunteering in the community. They're able to pay a portion of their rent. One's employed part-time. They've paid all their fees and fines associated with probation. So they're doing really well. Of the other 4 individuals that's been in the program, they've been discharged from the program, but 2 of them have completed probation and paid their fines. They're currently employed, they're living on their own, and they're still active in treatment and integrated care in the Lincolnton program. 1 of the 4 individuals has moved back home, but is still active in recovery and doing well. And 1 received a job opportunity and withdrew from services, but they still remain in touch with integrated care and they participate in the recovery community. So everybody that's been a part of this funding has done really well. And we're glad to see it. We know that housing and transportation and supportive services works. And even though this is a small program, it gives us some of the data to show that what we knew is true. One of the things to remember about substance use treatment is oftentimes relapse is seen as a huge failure. And lots of times because of that, the individuals in treatment feel shame. They feel like they're shunned for falling off the wagon. They're told they have to start all over again. That's kind of been the traditional way in substance use treatment to handle relapse. But you don't see that with other chronic diseases. What you find with things like diabetes and high blood pressure and diseases of that type is that the providers encourage people and remind people of previous successes that they've had and that they can manage their disorder. They're reinforced and encouraged. Medications are discussed. And oftentimes medications are adjusted to reduce side effects and to find medications people can afford and that are accessible to them. One of the things going on with medication-assisted treatment now is that we're getting there. In fact, you know, we know that when someone tests positive for unprescribed drugs, that's an indication that their medication-assisted treatment dosage may need to be adjusted, that they may need more treatment supports. So instead of the individual in treatment feeling shame and feeling isolated for the relapse they may have had or maybe for non-adherence and being discharged from the program, the team works with them to review their treatment plan and make the adjustments that they need in their medication or in their treatment or in their other supports. As far as a future focus, some of the things we need to see, of course, is more funds. We've done great with $10,000, and you know we're looking for diverse funding sources from local, state, and federal sources, as well as private sources. We want to be able to address more social determinants of health. We need to increase the housing that's available out there. We need to increase transportation services. One of the things we have found in Lincoln County that it's not just medical health that is a barrier to people going to treatment, but poor dental health, poor eyesight. And those are things typically people don't have access to when it comes to funding for medical services unless they're eligible for Medicaid. And a lot of our people that we serve, adults, are not eligible for Medicaid. It's the same thing with transportation. There may be some low-cost public and Medicaid transportation out there, but oftentimes they're very limited, especially in rural areas. There's not enough routes, there's not enough stops. Sometimes people are in situations where they may have to go out of county for service. And if that happens, they may be picked up in the morning, dropped off at whatever clinic they're going to, and then they have to sit all day long until the Medicaid transport can come back and pick them up. So that becomes problematic for individuals and retaining them in treatment. So those are some of the things we want to continue to look for in the future. I'm going to turn it over to Rebecca now to talk a little bit more in detail about the housing components that's been provided. And
all right. Thank you so much, Vanessa. And thank you, Mr. Williford, for allowing us to host this today. I am the site manager at ICGH Lincolnton, but I also am the manager of Day One Recovery Homes. And so I work a lot with the homeless population. And so many people struggling in early treatment just don't have housing. They don't have anything. We do focus a lot with the criminal justice system. And so when these people come into our program, they're broken, they're unsure, you know, they're walking the streets, they have no money, nothing. And we want to instill that hope that, hey, you know, we can do this and really advocate for these people and just get down and dirty with them. And so take women, for example, that come from intimate partner violence. This is a serious issue in our community, and they're not only broken, but they're frightened. And so we have housing away from other people. We don't disclose the address to our properties, and it tends to give them a feeling of safety. And so not only are we just providing them safe housing, but we're also providing them some trauma counseling. You know, we're really trying to do person-centered, a person-centered program with these folks, because it's not a one-size-fits-all model. You've got, you know, different backgrounds, different, you know, different obstacles that they're trying to get through. And so, and as you can see with the data that Vanessa just presented on the 6 participants, our structured program has proven to be successful. When you surround others in treatment that are already in recovery, it really helps them to reach treatment goals, especially when the residents have been there for a while. They actually become mentors. And so when they're mentoring, it not only helps the new participants, but it helps them also meet their own treatment goals. And so after they become established and stabilized in their treatment, they actually start sharing the cost of, you know, of the rent, and they're so excited to be able to do that. So then the county is only paying a portion of the cost. They're able to find employment. At many of our local factories, we're very fortunate in our area to have an industrial park that has just really accepted our community. And a lot of these factories offer insurance in around a 90-day mark. And so then they can actually come off the state-funded programs. And one good thing about these factories is that they hire people with a felony background, which is important because a lot of these participants struggle really hard finding work, because as soon as their record is revealed, a lot of times doors are closed, unfortunately. So they really get the true opportunity for a second chance. Most of these participants come into our program, they're going to be state funded, uninsured. But this data shows that we can prevent recidivism. The rearrest rate significantly drops. These people are able to get abstinent and remain abstinent for a long period. They are able to maintain employment. As we all know, jail is very expensive. We focus on keeping these participants from going back to jail. We provide the support they need, the resources to give them the highest chance possible for long-term sobriety. And in turn, they become law-abiding citizens. They become tax-paying citizens. They can take care of their own children. This helps lower the cost because we no longer need the foster care system.
Rebecca, if I may ask a question real quick, do you have any comparisons between the cost of putting somebody in jail versus putting them through the program? What the differential is there? Is it more expensive to keep them in jail? Is it more expensive to keep them in treatment? Obviously, that doesn't determine what is the best approach, but I'm just curious if we have any idea. I'm sure somebody out there does, but in terms of your costs.
Yes, Dr. Richardson can help with that because he's worked diligently with our local sheriff, and we've compared these numbers. Dr. Richardson, do you care to?
Yeah, well, we have actual data. Wesley mentioned earlier, and every county is a little bit different when it talked about jail, and it's about $8 a day. So about $140 a week. We provide transportation, electric, security, the insurance required for shared living in a treatment program, housing, and then we also match them with the state and federal funds available for treatment. And then they do become paying themselves their own way. It's an amazing program. We would not have gotten started without partners in the Lincoln County funds. And then to supplement the needed funds, we were able to open up our program for private pay. And so the private pay participants have been just as successful as the funded program participants. The program we believe in, it was something that was new to us. And then we went from the rentals to purchasing an 8-bed duplex, 4 for men and 4 for women. And so these are nicer apartments. These are nicer properties than what we started. And the success from our transitional program is really what led us to work with HUD and Kayla to purchase the apartment complex in Catawba County.
Thank you so much.
Thank you, Beth.
And lastly, I just want to, stress that during the peak of the coronavirus pandemic, we did not stop our outreach. My team and I continue to go to the jail, the shelters, the camps. That's normally where I'm at. I'm on the front lines. We continued outreach to homeless because it's so critical. It's just so important. We did not stop admitting people into our housing program. We did understand the risks. We educated staff and the residents, following all the CDC mandates and, NC Gov. We really dove deep into that to understand just what we were dealing with. We were able to provide testing. We followed any symptoms and had them to sign some releases. So in doing all of that, we were able to keep running. And so during this critical time when other programs had to shut their doors or shut their programs to new participants. And we are still providing this much needed housing. However, we cannot do it alone. We have great support from partners. Vanessa has been so wonderful. She is like my right hand on this. But we need more. Sadly, it's just not enough. And someone has to fund these programs. We need more creative funding to keep this much needed life-saving program, to really give these participants a real second chance at life, because the homeless population in Lincoln County, the numbers are just getting higher and higher. And with very little resources here, we've really tried to partner with the local coalition and a lot of other agencies just to see what we can do to help these folks.
Thank you very much, Becca. Speaking of partnering and coalition, our next speaker is going to be Fred Brayson with Ruth Trott from Project Lazarus, and there are many programs for prevention and outreach treatment.
One second here, I'll pull the slides up. Thank you very much, Corey, and good to meet you, Seth, and hopefully I'll be able to answer some of your questions that you had. Let me pull up my screen. Can you see the screen?
Not yet.
Not yet. Okay, one second. How's that?
I'm sorry, not yet.
Not yet. Okay, one second. Here we go. It's telling me it's failing to start.
Well, this happens in the real forums as well as the virtual forums. So
Yeah, it's open, but it's not. 1 second here. Let me move the screen. I've got more than one screen up, and that might be the issue. How's that? No?
not yet.
I'll give this one more try.
There we go.
You can see this?
Absolutely.
Great, excellent. Okay. Sorry to take those extra few minutes, but pleased to be able to share, what Project Lazarus is doing and what we're about. And for you, Seth, to understand some of what goes on in communities. And you've heard a great deal regarding, Catawba County and Hickory and what's happening there. And we experience here in Wilkes County much the same. We're kind of a flip of what Catawba County is. With a hub such as Hickory, our hub is about less than 15% of our population. All the rest are rural and out into the mountain areas and much more difficult to reach and to help, with the assistance that they need. But Project Lazarus, started addressing the opioid problem here in Wilkes County over 15 years ago. Obviously to prevent prescription medication and drug poisonings, present responsible pain management, and promote substance use treatment. And now we provide support services. My main points in just sharing this is prevention, intervention, and recovery are necessary across the board. We can no longer do one or the other. It has to be all three. And I think you've heard a good deal from Hickory and Catawba, and you'll be hearing more from others, how they're doing that. The model that we created through doing it here in Wilkes County was all encompassing, and the main thrust was to engage all community sectors to give them what they need to address the situation with substance use disorder within the population that they serve, whoever that may be, all ages from 0 to 105 and everybody in between. And I just wanted to give you a snapshot how we dealt with this from the harm reduction side with naloxone, syringe exchange, the treatment side for substance use disorder, making sure that all individuals have access to recovery treatment, whatever that may look like for them, with no stigma regarding which one or the other. And then obviously working with law enforcement and others in corrections with diversion control, pain patient support, and working with the hospital and community education overall. But to make sure we didn't do any harm in trying to do that, to make sure that we weren't leaving anybody behind and that we were addressing it across the board and not trying to help one segment of our population and injuring another by the work that we were doing, those unintended consequences, which unfortunately do happen. But the focus is on the individual. How do we reach an individual to help them in their time of need, whatever that may be in their present condition? And we realized in a rural county, especially in North Carolina, the way to do that because we don't have a hub, was to change the individual. We decided we needed to change the village. And that's why we addressed it through every community sector and helping them with the resources, the messaging, funding, whatever was necessary to bring about change in individuals' lives, to support on the prevention side from the early on to the cause and effect side of the after fact when they're already involved with law enforcement or they're already in full-blown substance use disorder, and everywhere in between. And that was how we addressed it. And that's where our success has been, and helping communities all over the country and in Canada, kind of mobilizing to do the same thing. And when I talk about cause and effect, every community will tell you that they have a drug problem. And for years, we worked on the effect, the crime and the financial ruin in the families, where now we're beginning to kind of turn our attention more into the cause, the biological factors, the cultural factors, environmental factors, depression factors, trauma, poverty, all lead to, coping mechanisms of how do I deal with this? And unfortunately, that drives a lot of substance use, which then turns into a substance use disorder. But historically, we've always dealt with it on this end and the supply end. And we've realized finally, and at least coming to that conclusion, that doesn't work, that we have to get to the cause end. And there's two different aspects to cause. There's the prevention end that I do with, with Hickory Integrated Care and Ruth, like working with underage drinking, ages 9 to 20, making sure that there's prevention on the early end, but then there's also the prevention on the end effect. Those who are in recovery, seeking recovery, the relapse issues, the triggers, the housing, everything that you're hearing about today are all risk factors that we as communities need to address to keep somebody from that relapse, from, returning to use. And, here in Wilkes, we were the #2 county for income loss for years as 2000 to 2014. And obviously that's the driving issue that we've had to deal with, but then all communities, especially with COVID now, have to deal with that also. And the way we've addressed that with funding, we looked at it, again, the full scope of prevention, intervention, and recovery. Here's just a list to give you an idea of some of the grants that we've been able to pull into Wilkes, and one of these has specifically to help out with Catawba, prevention, recovery, and then the full scope. Working on the prevention end for ages 0 to, through 20, and working on the recovery aspect and bringing in more substance use treatment, as well as the peer support mechanisms to address the surrounding RAP issues around that individual's life. But then also working with the justice involved individuals that we're implementing now. And I'll share a little bit more about that in a bit, because of the judicial aspects of appropriations and funding and legislation to kind of move from a incarceration only to a, intervention and treatment aspect, which I'll show you is obviously much cheaper. With the peer aspect that I know the Hickory Police Department talked about, that is vitally important, because an individual who is using and seeking recovery or in recovery needs that support. Nobody pretty much is going to walk into recovery all by themselves and successfully walk through it by themselves. It takes other individuals, it takes a community to completely, surround that individual so that there is increased abstinence, the housing, the employment, the social connectedness. And of course, with COVID, when we're talking about recovery, isolation is the enemy. And that is causing issues in about every community across the country. But we've, like was just shared out of Lincoln County, we have not stopped meeting with individuals and helping those individuals surrounding the CDC and COVID guidelines to ensure that there isn't a return to use, and helping them through that process. And just to give you an idea, and this is going back, the end of last year, just for 60 clients that peers were working with, you can see where in this graph where the extent of the needs of those individuals and what was more important to them in their place of recovery, their basic needs, the medical needs, the transportation, and the housing. Again, I'm talking about cause and effect. Without assistance in those areas, we move people into a higher risk category for them falling into relapse or continue to use. So it's vitally important for the community organizations to have that kind of funding, to have LEAD programs and others that are well financed, so that individuals through those basic needs can be met and recovery become a success throughout their entire life and sustainable. And we all know about the overdoses. 90% are unintentional. Studies have clearly shown that. And for me, an unintentional overdose is a preventable overdose. And it takes a community to, address that. But just to give you, Seth, an idea of what's occurred over time, when all of this kind of initiated, 15, 20 years ago with the opioid crisis, we look at the tox screens of those who have overdosed. And just to give you an idea, in 2016, obviously you can see oxycodone, prescription medications, was the #1 attributing factor, along with other things, but clearly the #1, regarding that. We moved to 2018 and we see a change. We see fentanyl, heroin, obviously are on the definite increase. Which clearly shows us we can deal with supply all day long, but if we don't realize the demand and address that, which is the cause, this is going to continue. It will only just change the supply line. And we're already seeing that with methamphetamine and cocaine, as the Hickory Police Department, mentioned earlier. So those are the shifts that communities are dealing with the overdoses and with the individuals who are using.
A quick question for you. Are folks, I see that the numbers and the major mentioned it earlier that the numbers on methamphetamine have been going up quite a bit. Is that at all, I mean, what is the relation between that and opioids? Is there any, if we've got somebody who had an opioid disorder, opioid usage disorder, or as we've cracked down on the ability for people to gain access to that, are they turning to methamphetamine, or is it just unrelated? Is there some other piece to that?
Well, there is a correlation, but I would say first, when we cracked down on the opioids, it was the heroin and fentanyl that became the next in-line drug to use. And when you understand what a morphine, an opioid derivative medication does, it's more of a, obviously somebody can get euphoria and high from that, but it's different from a methamphetamine. Methamphetamine is a stimulant. So you find people utilizing both.
Sedation, or they're using them together for sedation and for stimulation? Yes.
And we're finding more people in recovery with buprenorphine and methadone. Unfortunately, methamphetamine showing up in their drug screens and so forth. So it's still an added component. And here in Wilkes, we just in the past 2 weeks had a $2.5 million bust of methamphetamine that was coming into the county, just for our county. Part of the thing about methamphetamine, low cost, pumping in from Mexico, being made in the labs down there. We don't have lab issues anymore here because it's cheaper to buy it from the Mexican cartels that are pumping it in. And if you look at polypharmacy, most overdoses are more than one drug involved. 5, 6, 7, and 8 that we have seen. Very few are single drug only, and most of the time that would be a fentanyl because of the power of that. And the person probably not even realized whatever they took was not fentanyl related. So all of those are factors, yes. But where does this fit into the scope of a community and what we're dealing with? And I'll start with our child welfare, which is part of, DSS, obviously can be part of the court system, families and breakup. Just for those, investigations, you can see the correlation here between substance use and those entering into the child welfare investigation system is extremely high. Substance use is a driver, unfortunately. And our DSS is, overwhelmed. There's only so many foster care parents or individuals out there. So it creates quite a burden on those individuals. And then when it moves from an investigative stage into a case management stage where DSS is actively working, the numbers are even closer, that, nearly, 95+% are directly substance use related. So if we're not addressing the substance use of the individuals within that family, then it's just going to continue. So it's very important to have that intervention and for our DSS and our treatment organizations to have the funding in order to address that situation and not break up the families. As Wesley talked about, somebody getting their kids back. We've done that over and over here, but I can give you a long list of individual families that needs to happen with. And it's not an overnight process, it's an ongoing process. And when we look at the cost that you had asked about earlier, this is in North Carolina, minimum custody, medium custody, close custody, the average is about $37,000, $38,000 a year to maintain somebody in one of our prisons, which NIH says the average is about $24,000. So we're way above that, and probably those numbers are obviously increasing over time. But when you look at what is substance use, what is treatment cost, and this is from NIH, the National Institute of Health and National Institute of Drug Abuse. They figure about substance abuse costs our nation about $600 billion annually. But treatment for like a methadone maintenance treatment, buprenorphine treatment might be a little more, but you can figure about $5,000 a year versus $38,000 a year. There is a huge change in that. So when you have a LEAD program who is, steering and guiding somebody over into treatment and no incarceration because of the diversion of the charges, it's obviously saving money on the front end instantly. And then so it yields a return of between $4 to $7 in reduced drug-related crime, criminal justice costs, and theft, ratio of like 12 to 1, in savings. So obviously an investment into the substance use disorder treatment and the support around that for housing and all of the other aspects that you're hearing about, it saves money across the board. And that's an instant savings. That's not, down the road. But if our communities don't have the funding, as they were talking about in Lincoln and in Catawba, when you're talking about 8 families, 12 families, that's a very small percentage. It is making a great difference. Changing one life, one family is huge. How much more could they do with the funding that would be necessary, or the legislative changes in moving away from an incarceration model? Because then when you look at somebody who's been incarcerated, look at the overdoses. For somebody who was recently incarcerated and released, over 40 times more likely to die from an overdose in about that 2 to 3 week time frame from when they leave their incarceration place, whether it's a jail or a prison. So that is definitely a population that needs to be reached in their time in the pre-trial phase, like an L.E.A.D program, intervention in their lives, but also in the incarceration time and also in the post-incarceration. That if we don't have those kind of programs, these individuals unfortunately are dying. Returning to use, returning to crime, and the recidivism of an individual coming back into the jails, is huge. And this just kind of shows you the cause, overdose and the leading cause of death among incarcerated, the downward mobility, crime and violence, incarceration, network disruption, stigma and psychosocial stress. If somebody has a felony, you heard that they can't get housing, they can't get a job in most places because of that felony. It just keeps them in the system rather than helping them be removed from the system and become an active participant to help others and be an active participant as a resident and citizen of that county. So those are all factors that communities have to address. And looking at the Rhode Island program that launched a medication-assisted treatment program in the incarcerated individuals, it shows 60.5% reduction in opioid-related mortality when there was treatment available within the jail or prison for those individuals. It does make a difference. But just to show you in North Carolina, this is what we have at the end of 2019. 6 counties provide access to medication for opioid use disorder in a jail setting. So we definitely have a long way to go. There's been some lawsuits in Maine and Massachusetts because it goes against the American Disabilities Act, where somebody is supposed to have, healthcare treatment. If we're not looking at substance use disorder as a healthcare issue, then that's being missed, and that's a change that obviously we're attempting to make. So you can see from legislation to funding where some of these dollars need to go in order to bring about, change for those individuals' lives and bring them back into productivity within our communities. And then this is a paper that just came out, and I put the link here where anybody can go online to look at it. Situating the continuum of overdose risk and the social determinants of health, a new conceptual framework. And clearly the study shows aggressive enforcement of punitive legislation, including the criminalization of addiction, works against somebody who is seeking and staying in recovery. And an estimated 65% of the 2.3 million people in US prisons and jails have a diagnosable SUD. But so you're saying 65% of those in North Carolina incarcerated facilities, jail and prisons have an SUD disorder, and we're only seeing 6 counties with any programs when we have 100 counties. Obviously, we see a much greater need for helping those individuals. And not everybody needs medication-assisted treatment, but they do need recovery aspects within their lives in order to sustain themselves and not end up back into crime and then jails. And just to give you one brief outcome, you can look at our overdoses here in Wilkes County, 2015 and 16, 23 and 26 individuals, 2017 knocking those in half, essentially. And our work continues with the Bureau of Justice Assistance Grant. We're now going to be providing within the jail, everybody who is released with a substance use disorder indication is going to have naloxone on their person when they walk out the door, not have to walk out the door and get it. And we're working on a pretrial release program to where our peers will be working with those individuals. Again, much like the L.E.A.D program, getting on the front end, but then also working with our jail and prison so that we can work with individuals within those facilities, and then post-incarceration that we're already connected to them to provide support for the housing and the basic needs that are necessary. And there's more information on, Project Lazarus if you so want, or if you want more data, I can certainly provide that. And I wanted to give Ruth the opportunity, because she's the next speaker also, because our prevention work with Dr. Richardson and Ruth and Catawba, surrounds the underage drinking, underage use of potential for drugs, so that we're working on the prevention on the front end, and so that there's not so much effect on the back end, and that we remove generations that we currently have the situation with from falling into substance use disorder. And I appreciate your time and happy to answer any questions. But Ruth, if you'd like to, speak into this, feel free.
Thank you, Mr. Brayson. Good morning, everyone. I'm so thankful for the opportunity to share my small part amongst all these conglomerate programs and services in our community. As a prevention specialist, I began small commissions with agencies, representatives, with people that we were talking about the underage drinking, the issues that is growing on the use of the substance dependency in our community. We are an evidence-based model. We are developing and supporting community capacity to provide prevention, intervention, and recovery. So as per SANSA's strategic prevention framework, at the beginning of the year, I began to develop an assessment. So with that, I completed a community readiness survey. I went through the entire community in Catawba County, interviewed people from the law enforcement, teachers, social workers, healthcare workers, students, everyone that I can think of, so to obtain a diverse information. Well, I completed this information. I was able to identify those vulnerable populations and the disparities that they are experiencing, and solicited input about assessment findings with members, and describing these findings was so essential to that first step. The second step of this strategic prevention framework is the capacity. So I began developing the building of the knowledge, the resources, and the readiness that we may have to address these disparities in our community. Making sure that these practitioners understand the role of the cultural competence, and that develop the new partnerships that will engage members in prevention planning efforts. With this information, I believe that we are now ready to do the planning. The planning part will involve members in the community and decision making. The people that have been involved in the beginning were share all these results so that we know where we stand. And I'm gonna be grateful to say that we had the support of the 3 school systems, the Catawba County Schools, the Hickory City, and the Newton Conover Schools. They're so willing to participate and to partner with us, as well as the law enforcement and the public transportation. They are in network with us, and then we have a consensus view. We continue to work together and to be able to do the prevention, intervention, and recovery in our community. Don't have a PowerPoint presentation, but I wanted to share my goodie bags that I've been sharing in the community. This one addresses the talk about vaping and how to do a better connection, living well and healthy in our community. And also we have been sharing how to survive and thrive in our community. This is just a quick reference. It's a quick reference guide to help yourself and others in the community when there is any situation about to assist wellness and to achieve a better facing the way to face crisis. Of course, in the goodie bags, we also have a stress ball and our hand sanitizing products. So I just wanted to share that with all of you, and this is what I'm sharing in the community. Whenever I'm invited to go anywhere, go to churches, any agencies that want to listen and share with us, this is what I'm doing. Thank you.
Thanks, Ruth. I just want to add to that for Seth to understand, in working with Ruth and 5 counties on this project, we actually put together 10,000 of those goodie bags, and they're actually going to the children who are in the lunch programs within those counties. So when they showed up to pick up their lunches, they got these goodie bags, and we're doing two events trying to, to attempt to do that, so that not only do the children get something of their use, but then the parents or guardians, whoever they're with, get some information about the resources and the help that's available within the community.
Thank you, Ruth.
Thank you, Brian.
And Mr.
Thank you,
Williford, just like
that's very
with our
impressive.
just like with our work with partners and evidence-based models of care, we use an evidence-based model of prevention as well. We start with needs analysis, we move on to models that have been shown to work, and then always looking at the outcome data. And we are going to run a little bit over today. And like I said, this will be an entirely recorded educational forum that will be distributed. But we do want to move forward if there aren't any other questions. It's just been very educational. That's why it's hard to put a stop on anybody's talk. And thank you so much, Fred, for, as always, a very informative talk. I would like to move on to Ruth's specific talk, Mr. Williford. We wanted to highlight today the need for Hispanic outreach in our communities today, and let her talk a little bit about some of the programs she spearheaded in Catawba County through ICGH.
Thank you, Dr. Richardson. I'm sorry, I'm trying to run on time and speak fast because I don't want to go over time with anybody's busy schedule. But as a Hispanic community outreach, since there was an increased evidence of some racial and ethnic minority groups are being disproportionately affected by inequities in the social determination of health, as we well know. ICGH have provided access to care for non-English speaking individuals, the underserved and the undocumented through state funding, through Samson's federal funding, and it's wonderful that we are able to provide all that without no questions asked. We have also continued to partner with Central Latino, which is based here in Hickory. In Central Latino, we link individuals to provide immigration assistance through their Department of Justice accredited representative. This individual will do adjustments of legal status, DACA, which was put on hold, but they still have people consulting and finding out about what's going on with that, naturalization, citizenship, whatever legal needs they may have in this community. And also we have continued to partner with the North Carolina Free Legal Aid. Free Legal Aid helps free of charge to people with needs on housing, domestic violence, sexual abuse, child custody, and many other services. It is wonderful to have all this assistance and this guidance in these hard times. And lastly, I wanted to provide this, to mention that we're also providing ESL classes, completely free of charge. We provide translations and interpretations for all those individuals in need, which will keep these individuals out of prison, out of jail, and to access higher levels of employment and better access to healthcare and education. Also, at the same time, will allow them to be employable and to be able to tax pay. Everybody needs to pay the taxes in this country. So I am so glad for the opportunity given to share my small part. Thank you so much.
Thank you, Ruth. Unfortunately, Mr. Williford, there aren't a lot of funding streams. We actually just cover the cost ourselves for a lot of Ruth's work in the community. She translates for other agencies free of charge from us, teaches English to English classes here on site, and she hosts free clinics, legal clinics with North Carolina Free Legal Aid at all of our treatment centers. Right. And so she's just an amazing woman, and we just like to support her any way that we can.
Thank you, Ruth. Really appreciate it. And I'll also give a quick shout out. Dr. Richardson and I spoke about this ahead of the meeting a couple days ago, but the importance of reaching out to the Hispanic community and all minority communities across the state. I understand that a lot of the services being provided by each of you are very well addressing potential disparities or differences in how you're providing any care. And so just wanted to give a quick shout out to that and acknowledge the importance of the work being done both for Hispanic outreach and then more broadly the minority communities in our state. So thank you for what you're working on.
You do bring up an important part. While we do address special programs for the Hispanic population, our vice president has done some special programs herself, and our program director really does focus on creating treatment plans that meet the needs of special populations. So the deaf and hard of hearing populations, blind population, we actually have participants in our programs and using newer technologies and translators to help in these treatment planning efforts. And Stacy, if you want to just talk briefly about some of the other minority programs that we have so that we can address access to care that is an issue in our country today.
Really quick, within the African American communities, we have, Vanessa had a really good idea for us last year. We received an invitation with the Delta Sigma Theta sorority in Gaston County. So we linked up with them and partners and set up a booth down there and just really engaged ourselves within that community, passed out a lot of information, got to know people. Unfortunately, sometimes it's hard for people to just approach you with some of the questions they may have or some of the concerns they may have. And it was one of the best opportunities that I had to actually see people like me and then be comfortable and come up to me and say, hey, what can I do? And that opened so many doors for us to be able to say, look, hey, guess what? I do have something available for you. We have a funding stream. There's certain things that we're able to do. So that did help us within Gaston County. We are seeing an increase of the African American population within our program alone. I know for the 4 years I've been here, I have seen 3 or 4, and just within the last 3 months alone, we have been able to bring in another 5. So that we are trending on the up with that. We also are open. We've done the Hickory Ridgeview Community Center. So we've done a few things there to be able to just, engage with people in the community here in Catawba County. So we have some things that we are putting in place to be able to say, hey, we were actually looking into changing some of our promotional materials as well, just to promote, because if you look at statistics, a lot of times, African Americans right now, their problem isn't necessarily the situation with opioids, even though that is a problem. But when you look into crack cocaine and things, if they see some of our promotional materials, people may feel as though, oh, they don't support, my issue that I'm having. And so we are gearing up to putting things out there to say, hey, wait a minute, it's not just the opioid crisis. We also deal with these other issues along with trauma and things like that. And that's going to help us just open our doors a little bit more to other, minorities and communities. So that's just pretty much my little bit.
No, that's the core of the question that I had about, I have heard anecdotally in other similar conversations about, the disparity in terms of which substances are being used by which communities. And so I did want to ask whether opioids or methamphetamines were specifically a concern in the African-American community, or if there are others, which you pointed out. And I'll also put the same question to Ruth. Is it predominantly opioids that are affecting the Hispanic community, or are there other narcotics that are of concern? I understand that they're all of concern, but if there's any particular ones that seem to be jumping up.
Ruth, would you like to speak to that? I know that what you've told me is alcohol has been a big issue with a lot of the Hispanic community. Unfortunately, our funding streams right now, Mr. Williford, really do focus on the opioid crisis. And one other thing that Stacey forgot to mention is, or I can add to this, educational forums that we've been able to offer specifically for the African American Pastoral Association here locally. to give the pastors education, allow them to detect and refer when appropriate, and also educational forums for the deaf and hard of hearing. We've done regional educational forums as well. But you're absolutely right. There are some drugs that are specific to populations. But my work, I've done research with North Carolina Physicians Health Program, and that research with our physicians, PAs, and perfusionists have identified even certain careers do have specific drugs. And so this is historically very true.
And we do actually have a participant within our ICGH Hickory location that is blind. And, you know, we found ways to be able to communicate with her and work with her. I think iPhone actually has something to where if you turn the iPhone a certain way, you would be able to communicate in Braille. So we are able to send a text message to her and she can actually communicate and respond back. And so that has been an awesome experience for us as well, just to learn how to navigate these new avenues that we're, you know, being introduced to and figuring out ways to make these patients feel just as comfortable as possible.
Absolutely. Newer technologies have been key, even with COVID and our special populations. I know we're running over and I'm getting a few messages. I want to stay as close to on time as possible. And at this point, if we could move to Vanessa again, she's going to talk about our amazing SAMHSA program with medication-assisted recovery services.
Thank you, Corey. Yeah, Gary and I real quickly will talk about our medication-assisted recovery services program. And this is a program that's funded through a 3-year SAMHSA grant. It was awarded September 30th of 2018. We're now getting ready to wind up our 2nd year and go into our 3rd year. So this grant will end September the 29th of next year. Just real quickly, it is part of the MAT PDOA program under SAMHSA, which is medication-assisted treatment, prescription drug, and opioid addiction. So its main focus is on opioids, and the target population is for individuals that's under, excuse me, I've got a dog that's misbehaving. I know you hear that in the background. She's trying to tell me it's time for a treat. So I'm going to turn this over to Gary.
My dog does the same thing every day. You're fine.
Yeah, so this program is for the under and uninsured living with opioid use disorder diagnosis. And we have this program in Gaston and Lincoln counties. We're to serve over the 3 years a total of 160 people. We're already at 145. So we have had a lot of people come into the program. We do provide comprehensive services, medication-assisted treatment. There's a whole list on the PowerPoint that you can see on the screen. We also address things like trauma and stigma and social determinants of health. You have to have a holistic point of focus when you're providing substance use treatment. And most of the people that come into the program use more than just opioids as well. You were talking about other substances that different populations use. And while right now, I'm getting ready to get on my soapbox real quickly, but while right now, opioid is the quote unquote glamour drug that gets all the funding and all the attention, we need to realize that once we get it under control, other things like methamphetamines are going to keep popping up. So funding really needs to start to address a bit wider variety of substances. So Gary, I'm going to turn it on to you and go on mute and take care of my little issue here and turn it over to you. Gary? Okay, you may be having some technical issues.
There, can you hear me now?
Yes.
Absolutely.
Okay. Let me reshare that. For some reason, it wouldn't let me start speaking and sharing at the same moment here. There you go. Is that better? Can you still, can everybody see the PowerPoint now?
Yes, go right ahead.
Okay. Well, good morning to everybody. Thank you, Vanessa. I'm going to focus on 3 areas of emphasis. First, giving voice to the persons served in this program. who they are, what they think that works for them in the MARS program. Second are some of the accomplishments of MARS, and third is the challenge. And third is the challenges that MARS and programs like MARS continue to face, and we'll do that very briefly. As Vanessa's already described the MARS program and target population, I'm going to start with some details of those that have been served. As you can see on the slide, most are male, and this is consistent with national averages of those in medication-assisted treatment programs. Most are single with low educational achievement. In fact, a number of the folks do not reach or complete high school. Unemployment is high, and this does not account as yet for additional impacts due to COVID-19, though we are updating information relevant to the pandemic, and almost all persons served in MARS, as you can see, are uninsured. The last three bullets are of particular interest. It is established that if a person has 3 or more current social determinants, also known as social challenges or social opportunities, that this has an escalating negative impact on health, wellness, and quality of life. Fully 73% have 3 or more, which may include transportation, housing, food access, safety, and other specific determinants. In fact, here we do see the effect of the pandemic, because we have a 21-item social determinant screening tool. 17 of those have increased for those entering MARS or in a follow-up administration of the assessment. Prior to the pandemic, social determinants for those in the program had been trending down. So the resources to maintain basic needs while the person focuses on recovery and becoming an active member of the community are overall more and more stressed for resource providers in the communities. We see here that also that 38% self-report depression at baseline. This is likely an underestimate, as the use of substances is often to mask experiences of depression, anxiety, and for many, past histories of chronic childhood trauma and abuse. And finally, on this slide, we see that half of the population served in MARS have criminal histories of varying types, and that is also consistent with other MAP programs. Here we address MARS member experiences and summarize their feedback. Satisfaction with the program is quite high, as you can see. The MARS program is planned or adapted to make the program convenient for work, childcare, and other scheduling difficulties. Members have been involved in case studies featuring interviews and other methods, and have noted the success of the program in being non-judgmental, keeping an initial focus on resolving cravings and withdrawal issues, going for that initial stabilization, and then turning to and planning and establishing a long-term recovery plan and a recovery identity. So working a recovery plan to improve functioning has been supported, this is from the mouths of our folks being served, all 145. Working a recovery plan has been supported by group treatments, access to peer support services, and the MARS team checking in regularly and being nurturing to each other. Being nurturing to the person, supporting social networking, and providing a lot of opportunities. Some key issues for MARS, and there are still many challenges. Both of the providers have done a great job of adapting to different changes and needs, as Corey mentioned in the beginning when we talked about going strictly technical-based services with COVID coming along. That links to the first and most challenging issue, which is retaining persons in treatment. Again, partially due to navigating around the pandemic, but also by addressing key social determinants that interfere with program attendance. And that sounds, of course, we had no idea what other people were going to say, but this seems to be a recurrent theme that we're all finding here, is social determinants and not having access to resources. When we look at what's related to retention for MARS, we see that transportation, housing, finding and maintaining employment, and then if employed, having a job with some flexibility in scheduling to meet the treatment requirements, the hours available in the program, those can be stressful to the person served. And obviously for persons with less education will be in entry-level positions and may not have the same type of flexibility and adaptability within the program or within the employment structure, so the program then has to adapt and has done so as often as they could. MARS is also adapting to key issues that reduce retention in programs, and will further incorporate these in the next MARS grant that partners will compete for from SAMHSA. Vanessa mentioned these. We're going to focus on the pervasive effects of trauma. We're going to focus on depression and anxiety as key behavioral health issues linked to the opioids and other substances used. And of course, the deeply rooted self-stigma that manifests frequently as self-hate and despair in the persons who are going through this project and this program. My last slide, trying to keep within my time frame here. My last slide reviews some of the MARS outcomes that were part of the grant approved by SAMHSA. There are 16 outcomes, most of which are being met, as you can see. Here's some of the key findings. Program attendance is critical. The right dosage is not just for medications, but for the recovery-based services that build the recovery identity. There's been a shift, for me and for many of us who work in this field, not a real pleasant shift in the way medication-assisted treatment is thought. The actual name kind of tells you what it's supposed to be, medication-assisted treatment. And there's been more and more emphasis on medication and less on the recovery-based services. We think that's having a negative impact on the overall outcomes. And so, we are strongly supporting these additional recovery-based services. As you can see, for those that maintain the program for around 6 months, the attendance to planned sessions and meetings is 86 to 97%. That's really a phenomenal success rate. Again, this is for the group that are retained. The reduction in illicit substance use is trending positive. And as we accumulate more data, we will make more of a numeric estimate on that. Right now, we just know from the data that we have that is trending towards positive. Remember when I noted that the impact of 3 or more current social determinants on wellness and quality of life is quite impactful. Here we see 90% of those in the program have an improvement in at least 2 determinants. But again, this is prior to COVID-19 impacted data, and that data is just now coming in. Social networks have increased for about half, and this has been impacted by the pandemic. We all know, and we should just kind of keep in mind that for many of the persons served, their pre-MARS social network, their pre-treatment social network was often very reinforcing of using substances. It was their, getting high buddies. When they go into treatment, they need to moderate or even eliminate those social networks and build others, which is challenging while dealing with withdrawal, the introspection of recovery, the risk of a lot of isolation, and now a pandemic that's keeping people more and more homebound. Finally, it's critical that MARS service delivery follows the program fidelity, and as you can see, that's been extremely successful. We don't often get anywhere near that high a level, but the two programs have been phenomenal in following the model, and we're very happy about that. That's it for me, unless there are any questions, and I can turn it back over to Vanessa.
Okay, I do want to just take a minute to talk a little bit about our future focus. We are going to look for another SAMHSA MARS or Matt Padoa grant, as well as other grants that may be out there to fund opioid and other substance use disorder focuses. We want to be able to also find funds that incorporate into support services that we've talked so much about today and the things that you continue to hear about. One of the things with this grant is that it's a 3-year grant, and it's not quite enough time to get to where we need to be. Grants with a 4 to 5 year length generates a stronger infrastructure for us to sustain programs. With the 3-year grant, you spend the first year building up the program, doing outreach, getting people into it. In year 2, you're into a really strong program with effective services. And then year 3 hits, and you're going to have to think about downsizing, which is kind of where we are now, that we're continuing to look for funding. So building sustainability is a large part of the ongoing program from the start, but an extra year or 2 can certainly ensure strong components and ongoing funding are in place to keep the recovery effort going strong. So, recovery is possible, recovery is needed. We just need the treatment as well as the supports to make it successful. That's it for me, Corey, unless there are questions.
There any questions for Vanessa and Gary? And I really do appreciate everybody holding on a little bit longer today. I'd like to if there are no questions at this time. And of course, afterwards, Mr. Williford, you can email anybody directly for more information or meet with them one-on-one directly, which often happens. I'd like to move on to Tara Conrad with Partners and allow her to speak.
Hi, good morning. I'd like to take a couple of minutes and talk about the unique initiatives we have implemented as a result of the state opioid response funding, or SOAR as we like to call it. I believe you've heard from several speakers today about different funding streams, grants that have been applied for, and some of the services they are able to utilize with that. So I'm going to talk about some we're able to utilize with the SOAR funding. This specific allocation is designated for the treatment of individuals living with an opioid addiction and who are indigent or have no means to fund their substance use treatment. Partners, in collaboration with our treatment providers, use the funds to pay for medication-assisted treatment, or MAT for short. This specific type of treatment is evidence-based, as you've heard earlier, and it's proven to yield positive outcomes if delivered to the fidelity of the model. It is designed to provide a whole patient approach to the treatment of substance use disorders. MAT uses both medication and behavioral therapies to help decrease the individual's dependencies on opioids and increase their engagement and retention in treatment. This approach has proven to be effective in improving patient survival, treatment engagement, and sustained recovery. This enables individuals, once hampered by their addiction, to re-engage productively with society, gain employment, decrease or eliminate illegal behavior, and reduce recidivism in the local jails and emergency departments. The state opioid response funding has allowed partners to work with our provider network to expand medication-assisted treatment programs throughout our service area. The funding has also allowed for peer support services to be embedded in several of our opioid treatment provider agencies. This specific service is provided by a person with lived experience who has been trained to support those who struggle with mental health or substance use. Their personal experience with these challenges provides a unique level of expertise that many licensed clinicians do not have. Studies have demonstrated peer support specialists have had a positive impact on the members initiating treatment, staying engaged in treatment, and sustained recovery. With the use of the state opioid response funding, we have been able to expand our substance use treatment continuum. In addition to the previously mentioned services, we were able to help establish several Medicaid-assisted recovery anonymous support groups. Members using the medication to help in their recovery needed a non-traditional 12-step program to connect with others struggling with the same issues they were. The support groups provide hope in a non-judgmental environment, which helps individuals stay connected and engaged in their treatment. All of the services mentioned above are not only assisting individuals to initiate and engage in treatment, they are cheaper than the alternatives such as detox, hospitalization, or incarceration, as you've heard earlier. In addition to utilizing the state opioid response funding, we continually seek ways to blend funds and collaborate with our community partners to address the opioid crisis and other behavioral health needs. We focus on treatment services, addressing social determinants of health, and the overutilization of our local systems, such as the emergency departments, jails, and community-based organizations, when mental health or substance use is the underlying cause. In addition to our treatment providers, our county officials are in the communities helping to address the needs of their citizens. They are wonderful to work with, and we've been able to utilize county dollars to implement some unique services tailored specifically for the county's individualized need. I think you've hit on that earlier when you talked about each county having their own unique special or specific substance use that the members tend to use. We try to tailor services to meet that individual county's needs. As the local managing entity and managed care organization for this area, Partners is committed to helping members receive the services they need through community investments and partnerships. We utilized our Medicaid savings on several services in our communities. A few examples include supporting the expansion of transitional housing for members in recovery, funding overdose response teams, and supporting the law enforcement assisted diversion program you heard about earlier today. I mention this to highlight funds are always needed to address issues our members are facing on a daily basis. However, partners, our treatment providers, community agencies, and local government work well together to meet those needs. We appreciate your willingness to hear about some of the wonderful things going on in our community. And
Thank you
I'll
so much,
answer any-
Tara.
Pleasure's all mine. I appreciate it. Thank you so much.
Thank you, Tara, for stressing the importance of lived experience with our peer support. We also employ peer support, and due to our 12-step facilitation model, our therapists and licensed providers and certified counselors come to the table with that same lived experience, and we use a recovery-oriented model, a 12-step model that incorporates medication-assisted treatment. And as always, we really do appreciate the support of partners. Mr. Williford, we have one final person, and this is Judy Dahlstrom. She's a project director for a new SAMHSA grant, a new program, assisted outpatient treatment.
Hello, everyone. Can you hear me okay?
Absolutely.
So I'm going to go through this a little bit quickly, but I will say that this is our newest SAMHSA grant at Partners. We got started about a month ago, and so what I'm going to give you is more of a high-level overview of what we're planning to do, whereas some of the others were able to give you actual outcome information. So assisted outpatient treatment, or AOT, is treatment under a court order for adults who are seriously mentally ill and have a history of hospitalizations or arrests. There are a lot of reasons that AOT works for our communities. You can see here that AOT services reduce arrests and violence. People involved in AOT services are, for example, 4 times less likely to perpetrate serious violence, as well as half as likely to be victimized. For taxpayers, AOT has a gracious savings advantage. In New York, where AOT has been implemented, there has been a 50% savings in costs of services to the communities, including hospitalizations, inpatient hospitalizations, and jail time. In North Carolina, where AOT has been implemented, they have realized about a 40% cost in savings. So it's very significant money. And then, of course, for the most important reason, of course, is for the opportunity to help people get better and experience recovery. So for those with serious mental illnesses, about 77% experience fewer psychiatric hospitalizations, 74% experience less events of homelessness, 83% experience fewer arrests, and 87% fewer incarcerations. And those are really significant numbers and a real opportunity for us to make a difference. Generally, our overview of the grant, and like I said, we just got started on August 1st, about how many days ago? 26 days ago. We have $4 million over the course of 4 years. We are bringing 6 different counties of our 9 counties on board. I've got the counties listed there and in the order of onboarding. And what we're going to do is a case management model of services. So I envision this as being kind of a wraparound opportunity for our folks on outpatient commitment orders. Generally, we have some overarching goals, although these break down into about 15 other smaller goals. But we want to be able to lower the cost of high use and ineffective services. We want to improve treatment adherence. A big part of what we intend to do is lower perceived coercion and work to eliminate resistance or reduce resistance on the part of those being served. We want to improve disruptive symptoms that usually take place in the community, implement our model with fidelity, and engage our community so that we can sustain this moving forward. Generally speaking, we'd like to serve about 300 people. Folks will need to be 18 years or older and have a serious mental illness. Our focus will be on schizophrenia and schizoaffective disorders, and of course, those who are in need of required judicial support to adhere to their services. And lastly, one of the parts of this grant that is a little bit different from the other grants that we have is that we have a large portion that will be data collection and research. And so Dr. Gary Wallaby, who spoke with you with Vanessa Anderson's grant, will be leading that charge, and will use a change of theory. And we're hoping to prove that the case management model of this demonstration will prove to be effective and have some real significant outcomes. And so there are lots of data points that we're going to collect and be able to compare and provide results on in a year or two. And that is all that I have. And would like to say how much I appreciate this opportunity to share this information, and would be glad to answer any questions either now or through an email. So thank you very much.
Thank you, and congratulations on the grant. Looking forward to seeing the outcomes. I mean,
yeah, it's exciting. It's very exciting. Thank you.
And that, of course, applies to everyone who's been successful in receiving federal grants. And of course, we're happy to assist in any way that we can in either identifying or supporting your efforts in getting federal grants. You know, there's ways we can help, and so if there are limitations as well, but if there's a way we can help, we're happy to do it. So. Happy to chat with y'all further. I'll make my email is hidden amongst all the email addresses in this thread, but I'll make sure to send it out so y'all have my contact information.
Would like to thank everybody today, especially Senator Tillis for the invite, and Seth Williford for being his representative today. I'd like to thank our guests, including Jenny Connor, who from United Way of Catawba County, and all the speakers today. This is extremely informative and educational, and I look forward to working again with Senator Tillis's office, partners, Project Lazarus, and HUD to do some more of the educational forums. Thank you all very much, and have a great rest of your day.
Thank you, everybody.
Thank you.
Thank you all very much.
Take care.
Stay safe.